My task is to talk about technology-based pre-screening, and I really want to stress that this is pre-screening, and I will come to this back in a minute. So this is my conflict of interest, so we do a lot of trials. So this is, I have some honoraria for lectures, and I have some research funding from Boehringer Ingelheim and from some official institutions. So there are a number of devices that are available for pre-screening, and I will come to that in more detail. So we have devices like this stick that you just take in your hand, and then you have a single channel ECG because you have it in both hands. We have devices that are linked to smartphones, like this device where you put your thumbs here, and this is the data gets analyzed by your smartphone. We have something like belts that you have around your chest that are connected to smartphones. We have this Zenicor device that Professor Rosenquist has already mentioned. We have analyses available for single lead ECGs that you put on your chest. We have devices that do blood pressure measurements and they just analyze the heart rhythm for abnormalities. You may use your smartphone and put your finger on the camera, and this has been used for AF detection. And we have patches available like this one, the Zio patch that you just put on the chest of a patient that can be worn for 14 days and will continuously monitor an ECG. I want to go a little bit into more detail in a minute, but first some general considerations. The yield of AF in patients with paroxysmal atrial fibrillation is mainly a function of time. The longer you look, the more you will find. So if I do a device for 30 seconds, AF has to be present. If I have a device that works continuously for 14 days, I have a higher chance to get something. And probably the gold standard are implantable loop recorders. I will not go into this topic because it was not part of this, but we have devices, we have pacemakers that will come in the next talk that can do continuous monitoring for 2 or 3 years. The second point to consider is most atrial fibrillation episodes are asymptomatic, and this is also something that Professor Rosenquist already mentioned. So pre-screening based on symptoms, e.g. As an example, pre-screening triggered by the patient will miss most of the episodes. Most episodes are asymptomatic. And the third and very important point is pre-screening has to be user-friendly, and the typical AF patient is not a smartphone maniac. That is something that I really want to stress, because there are a lot of things that we maybe in the room think that would be good for us, and we would like to have this as a fitness tracker or something like that. For us it works, but the typical AF patient is 75 years of age or older. So the Zenicor device, it's a device that records the ECG for 30 seconds. You have a single lead ECG, and you have here some examples. This is from Professor Rosenquist's group. You have a patient with atrial fibrillation on the top, and you have sinus rhythm here, and it looks like this is something from the paper. It looks, oh, this is a quite convenient feature, and you really get a very good ECG. What I like on this device is the patient only has to press it for 30 seconds, and then the signal goes wirelessly with a mobile network to the sender, and you can read it anywhere in the world if you just go into the cloud. This means that is something you only have to tell the patient, do this for 30 seconds twice a day, and the rest of this is automatic. So it does not have to be linked to a smartphone, and you have to have you only have to have mobile access. That's all that you need. Then there are some iPhone or smartphone-based screening methods. For instance, this is the AliveCore, probably the most popular one. You buy this device, it's something like 100 or 120 euros, and you put your thumbs on there, and then you connect it to your smartphone, and you get a very nice ECG, and I hope this video works. It's from their homepage. You see? Oh, does not work. Okay. Sorry. You would have seen that there you see it. This is how it works in life, and you see a patient with atrial fibrillation. You see the irregular rhythm of the ECG script. So another possibility is pulse waveform analysis. This is something that was done with the iPhone 4, and there are at least 2 publications now. You put your finger on the camera of the iPhone, and then there is an algorithm that is based on the analysis of the RR intervals. And this showed a pretty good sensitivity and specificity for atrial fibrillation, so you see 97 and 94%. If you say we want to differentiate this from premature atrial contraction or premature ventricular contraction, you see this is a little bit more difficult because the algorithm mostly works on the irregular RR intervals. And if patients, for instance, have often ventricular contractions and ectopic ventricular ectopic beats, it's very difficult, often depending on how many of these premature ventricular beats you have for this algorithm to differentiate this from atrial fibrillation. Then the next device is the MyDiagnostic. This is the stick that you just wear, and here again you see a very nice sinus rhythm ECG, single lead ECG written with this stick, and on the right hand side you see a patient with atrial fibrillation. And now I come to some comparison between different devices, and that was this is a paper that compared 3 devices for the screening in primary care. The first device is the Watch BP device, so this is a blood pressure device that just analyzes the RR intervals. The second device is this OM1 device. You put it on your chest and then you get a single lead ECG. And the third device is the Merlin ECG, which is something like a phone that you have on your wrist. And here you find the diagnostic performance for the Watch BP and for the OM1 device, and you see that the sensitivity was pretty good in all cases, but that the OM1 device had a much lower specificity than the Watch BP, the blood pressure device. And so the author concluded that the Watch BP performed better than the single lead ECG monitors, as a triage set, because it does not require any expertise for interpretation, and it reduced the number of diagnostic tests that had to be done after that. What I really want to stress is, whatever we use as a screening device, we have to see an ECG where a physician says this is atrial fibrillation. We cannot base any anticoagulation decision on something like the algorithm showed a risk of 80% for atrial fibrillation, and this is the reason why we anticoagulate the patient. So in the end, we always need an ECG to confirm this is atrial fibrillation, and this is probably the reason why why my talk is entitled pre-screening, because we need something where we really see this is atrial fibrillation. We need an ECG, and the physician has to make this decision. So quite recently, just in January, another comparison study came out which compared the AliveCore with the Watch BP device. So again, this is the device linked to the smartphone with this sensor, with the Watch BP device, 2,000 patients. Here you see the numbers of those where atrial fibrillation was correctly diagnosed. The gold standard was 12-channel ECG. So these were patients. They get the 12-channel ECG, and then they get the measurement with both devices. So it's mostly also devices for permanent AF. They have to have AF at this moment. And you see here that in this case, 2/3 of the cases were found, and in this case, 83% of the cases were found. So the sensitivity of this device was better than the sensitivity of the AliveCore device in this comparison. So there are so many different devices, and this table is just to tell you there has been a large effort, and I think some of you have sponsored this effort, the AF Screen consensus meeting that took place in Rome last year, and this group has published a paper that has been accepted, and I think it will be published on the 4th of April in a major cardiovascular journal, and you will find this table inside this journal. So this is just to tell you this information will come out published soon. So when we think about the devices for pre-screening, we have to say ECG diagnosis is always required for validation of AF diagnosis. No therapeutic actions, e.g. anticoagulation, can be taken prior to validation of the diagnosis. And handheld ECG devices have the device that we already have an ECG strip that a physician can verify. There are some pitfalls I want to tell you. So One pitfall here was published by Thielemann. These are the pitfalls with this stick, and these are two examples of false positive cases. So this is mostly for the cardiologists here in this audience. This is not atrial fibrillation, but was classified as one. This is a case where the patient has a lot of ventricular premature beats. You see these, the QRS complexes are a little bit wider here, this one, this one, this one, this one, and this gave the algorithm the information this is irregular, and so this was a false positive because it's not atrial fibrillation. The one here on the other side is much more complicated. This is atrial flutter that is irregular in the conductance, so it's not atrial fibrillation but atrial flutter. We probably would treat it similar to atrial fibrillation, but it's not atrial fibrillation by definition, it's atrial flutter. And I also want to mention that I have some sympathy with Holter ECG because I get more than one channel. I get 2 or 3 channels. And you see here tracing, this is from Holter ECG, this is from an external event recorder, and this is from an implantable cardiac monitor. And if I would ask you in the room here, which of these cases are atrial fibrillation, probably everybody would agree this is atrial fibrillation. You see it's irregular, you see 2 channels, this is really atrial fibrillation. These other cases only have a single lead ECG. If you look to them more closely and have some more time, you will find both of them are also atrial fibrillation, but it's much harder to get this information from this tracing than from the Holter ECG tracing. And I want to do a small excursion to a population that I think we really should do more monitoring on, that is the stroke population. And I know that some of you work for companies which are doing trials in the embolic stroke of unknown source population. And I want to give you an idea about, a different idea when we think about stroke. Remember, you have a patient who unfortunately has 2 strokes in his life. So a first stroke and the second stroke. And most of you think etiology of the stroke is the same, but we know from data, for example, from the London Stroke Registry, that about in half of the cases, the etiology of the stroke changes between 2 events. So what we have done in the past is something that I call retrospection. We have looked at the first stroke and we have to try to explain the stroke. This is human. We want to know, why did I get a stroke? Can you give an explanation to me? Why did it happen? Can I find an explanation? Does it look, we called it cryptogenic, now we call it embolic. Should we anticoagulate? We know atrial fibrillation comes in clusters. This is the reason why intermittent atrial detection for atrial fibrillation, as for instance in the stop stroke study, is so effective. So a different approach, we call it look ahead in the FIND-AF randomized trial, was we think all stroke patients have a high risk of underlying atrial fibrillation. If we talk about the CHETS or CHETS-VEST score, we don't say somebody with a cryptogenic stroke gets more points than somebody with a lacunar stroke, or somebody with an embolic stroke of an unknown source gets a higher point than somebody with a stroke caused by carotid artery disease. We think all stroke patients have a risk of atrial fibrillation and should be, as risk patients, looked for AF. And if we find atrial fibrillation, we anticoagulate it, and we have the chance to prevent all the strokes in patients who, in the first stroke, maybe had a stroke caused by carotid artery disease, were treated by an operation, but get the second stroke 2 years later caused by atrial fibrillation, because we have often competing risk factors. Risk factors for atrial fibrillation are also risk factors for atherosclerosis. And one trial where we analyzed this, and this will be published in the April Lancet Neurology, was the FIND-AF randomized trial. This was a quite pragmatic trial. 400 people with stroke, aged 60 years and above, and no atrial fibrillation in history, were randomized to usual stroke unit care or a prolonged Holter monitoring for 10 days at 3 time points, at the stroke, after 3 and after 6 months. And we found an increase in atrial fibrillation, a 3-fold more atrial fibrillation in the intervention group, 13.5%. After 6 months, this was the primary endpoint, 4.5% in the control arm, so 9% absolute difference. Number needed to screen 11. And we saw a reduction in strokes. That was not significant because the sample size of 400 people was too small for that, but there were less strokes in the intervention arm as compared to the control arm. And if we looked into the subgroups, we did not find that those with non-cryptogenic and cryptogenic stroke had different weights in AF detection. So it seemed like, independent of the stroke subtypes, patient benefited from screening. And if we look for what are candidates for monitoring, for prolonged monitoring in stroke, and this is coming from the two main centers of this study, they screened during the time when we did the trial, we screened 1,604 patients. That were all patients who had a stroke and were 60 years and above. And 370 of them, so nearly 20%, were offered study participation. And you see the main reason why they could not participate were they already had atrial fibrillation or they had a history of atrial fibrillation. About 2/3 of those we asked for participation were enrolled and randomized. So it means that if we take these patients with atrial fibrillation out, we can say 30 to 50% of all stroke patients free of AF are candidates for monitoring, much more than we do at the moment, probably. We also used this Zenicor device in this trial. We used it for those who were not willing to have the second or third Holter ECG. And this is also some of the pitfalls I want to share with you. So we offered this to those who were not willing to have the Holter ECG at the second or third Holter ECG. And you can see here the compliance with the Holter and with the alternative Zenicor. So in the beginning, nearly everybody got the Holter ECG monitoring, and it worked. In the mean, it was 9.5 days. You see at the 3 and at the 6-month visit, the median duration of monitoring was similar, but the patients who were willing to have longer monitoring declined from nearly 100% to 75% and to 75%. We offered the thumb sensor to patients at the second and third visit, and you see that we're 7 or 10%. And I have to admit, we did not find any atrial fibrillation by the thumb sensor. And I want to share with you the longest AF episode. The problem was, in this case, our endpoint was, in accordance with guidelines, 30 seconds of atrial fibrillation. The device only monitors 30 seconds. So really atrial fibrillation has to be for the whole monitoring time. And you can see here that in the lowest line, this very much looks like atrial fibrillation. But here you can clearly see a P wave. And so this patient did not fulfill the criteria for atrial fibrillation. We asked the patient to come in for another Holter ECG, but the patient said, I didn't want to have the Holter ECG again, and so we missed this case. And maybe this was somebody with atrial fibrillation, but we were unable to prove it in this case because we only had 30 seconds, and if we had something like 2 minutes or 5 minutes, we would have had a higher chance to get this. The last story I want to tell you is a trial that is from David Gladstone in Canada. He's the first author of the Embrace trial. That was the first trial to be monitoring trial in cryptogenic stroke. That's the Screen AF trial, very pragmatic trial again. Patients 75 years of age and older and treated for hypertension. That's the only inclusion criteria. Will be randomized in a one-to-one fashion to a control group or an intervention group. The intervention group will have monitoring with the patch, with the diode patch. So we will have a continuous monitoring for 14 days. And in addition, there will be the BP watch monitor that I explained to you will also be used. So both methods can be combined and can be compared, but the randomization is against control group. And this trial has included nearly half of the patients. And happily, we will also have the opportunity to open some German sites, so some European sites to this trial. And we think that the results of the trial, primary endpoint is atrial fibrillation after 6 months, will probably be presented at the end of the next year. So in conclusion, Devices that use algorithms to detect rhythm irregularity are mainly able to detect persistent and permanent AF. There is the risk of false positive results. ECG documentation is always mandatory. Handheld ECG devices with verifiable ECG tracings are preferred because you already have the ECG, and the duration of monitoring is the most important point. Thank you very much for your attention.